Welcome back to the deep dive. Our mission today is, well, to really get into the weeds with some highly detailed anatomical sources. We're aiming for a truly professional level understanding of a surgically complex area.
That's right.
We're deep diving into the essential exocrine system of the oral cavity, the salivary glands. Think of it as where, plumbing meets some very precise high-stakes wiring.
Exactly.
We'll be focusing heavily on the parotid, submandibular, and sublingual glands, and especially those intricate nerve pathways that surround them.
And when we talk about anatomical mastery here, it's really about moving beyond just textbook definitions. It's understanding the three-dimensional relationships, how the major nerves, facial, lingual, hypoglossal, actually sit relative to the gland capsules in their ducts.
That's spatial understanding.
Precisely. That knowledge is absolutely non-negotiable for performing safe surgery in the head and neck region. There's just no room for error.
Okay, so let's maybe unpack the basic physiology first. We're discussing exocrine glands, right?
Oh.
They function by discharging saliva through these, often long ducts into the mouth.
Mm-hmm.
And while we tend to group them together, their primary function is actually pretty complex. It's definitely not just about lubrication.
No, indeed. Saliva is one of those things you don't really think about until it's gone, but it plays this vital triple role. First, the obvious one, mechanical lubrication. It makes the food bolus soft, slick, essential for deglutition, for swallowing.
Right.
Without enough saliva, swallowing becomes, difficult, even painful.
And the chemical part.
That's role number 2, initial digestion. Saliva gives us enzymes, mainly salivary amylase for starches, and a bit of lingual lipase too. But arguably the most critical role, often overlooked, is protection.
Oh, okay.
Saliva is a vital barrier against desiccation. It stops the mouth drying out. And it's packed with antibacterial stuff like IgA, immunoglobulins, plus buffers that control pH. Protects teeth, protects the soft tissues. It's really quite amazing stuff.
That protective role really underlines why problems with salivary function can cause such widespread oral health issues, doesn't it?
Absolutely.
Now, structurally, our sources draw a really clear line between the major and the minor players here.
Yes. We're focusing mostly on the 3 major pairs, parotid, submandibular, and sublingual. But, for context, we have to remember there are hundreds, literally over 400 of minor glands scattered around.
Wow, that many.
Oh, yes. And the key anatomical difference is simply distance. The minor glands are right there, within the oral mucosa or submucosa, think tongue, palate, lips, cheeks, tonsils. The major glands, however, they lie some distance away from the oral cavity.
Which means they need those longer ducts to deliver the saliva.
Exactly. And their secretory differences really highlight their specialized jobs. They all make saliva, sure, but it's not all the same stuff.
Right, the composition varies.
This compositional breakdown is really key to understanding the mouth's chemistry. So the largest gland, the parotid, produces mostly a serous secretion.
Serous meaning.
Think thin, watery, enzyme-rich. Great for starting starch digestion. Then you go to the sublingual gland, and it's the opposite. It's predominantly mucinous.
Thick and goopy.
Pretty much. Thick, viscous, rich in mucus, perfect for coating and protecting surfaces. And then the submandibular gland, sitting kind of in the middle anatomically, it's also in the middle chemically. It gives a balanced seromucinous mix.
A bit of both.
A combination of that thin enzymatic fluid and the thicker protective mucus. Covers all the bases, really. Hashtag to developmental timeline and ductal systems.
Okay, understanding the adult setup is crucial, but let's rewind a bit. How does this dense system actually develop? The embryology seems pretty consistent, involving something called branching morphogenesis.
That's the key process. It's this dynamic interaction where the oral ectoderm, the surface layer, interacts with the underlying neural crest mesenchyme.
So epithelium and connective tissue precursors working together.
Exactly. The epithelium dips in, invaginates, elongates to form the duct system, and the mesenchyme wraps around it, forming all the connective tissue, the capsule, everything. What's really fascinating, though, is the strict timetable they follow.
A specific order of appearance.
A very specific chronological order for the major glands. And knowing this is actually quite important clinically for understanding potential birth defects.
So who appears first on the scene?
The parotid gland. It's the earliest starter by a fair bit, beginning around 35 to 36 days after fertilization. It kind of lays down the blueprint.
Okay.
Then comes the submandibular gland, showing up after 42 days. And finally, the sublingual gland is the last of the majors, starting around 47 days post-fertilization.
And why does that sequence matter professionally?
Well, if something disrupts development during those specific windows, it can selectively affect just one or maybe two glands. That's how you can get conditions like aplasia, a gland completely missing, or hypoplasia, where it's underdeveloped.
Makes sense. In the minor glands.
They develop later, more simply, within the submucosa, without all that complex branching the major glands need.
Okay, so once they're formed, they need their ducts. These seem like defining features in surgery. Let's start with the parotid's plumbing.
The parotid duct is Stenson's duct, and the parotid gland itself is unique because as it grows, it basically swallows up two really important things: the branches of the facial nerve,
The big one for surgeons.
the absolute big one, and also local lymphoid tissue. That's why the parotid can be a site for cancer metastasis or even primary lymphomas. It's got lymph nodes right inside it.
Interesting. Now, the submandibular duct, Wharton's duct, it has a very particular path near the tongue, right?
It does. The duct of Wharton comes off the deeper part of the gland, travels forward and up, just lateral to the tongue muscles. Its opening, the sublingual papilla, is right near the midline, just under the tip of the tongue.
And its path makes it vulnerable.
Its superficial course in the floor of the mouth, makes it very vulnerable during certain intraoral procedures. We'll definitely come back to that.
And the sublingual glands, they're different. Not really one gland with one main duct.
That's a key anatomical point, yeah. The sublingual gland is more like a collection of distinct smaller glands working together. Their individual ducts mostly survive as numerous little ducts of Rivenus.
Rivenous. Okay.
Most of these open independently along that fold under the tongue, the sublingual fold. Sometimes, though, a few might fuse together to form a single, larger sublingual duct, which is often called the duct of Bartholin.
So surgically, you're dealing with potentially many small openings, not just one main pipe.
Exactly. It's a more diffuse system to navigate compared to the parotid or submandibular, ###3, surgical surface, and clinical anatomy.
All right, we've got the internal architecture. How do we find these things on the outside? For clinicians, knowing the surface markings is step one for examination and surgical planning. Let's start with the parotid, the biggest, most obvious one externally.
Yeah. The parotid sits in that space just below the zygomatic arch and directly in front of and slightly below the external auditory canal, the EAC, and the temporomandibular joint, the TMJ.
Okay.
Surgically, you think about its boundaries. Posteriorly, it aligns with the back edge of the mandibular ramus and goes back towards the mastoid process. Anteriorly, it rests right on the masseter muscle.
And the duct itself, Stenson's duct. Is there a line we can draw on the face to locate it?
There's a highly standardized marking for it, actually. Imagine drawing a line from the lower edge of the tragus of the ear.
The little flap in front of the ear canal.
That's the one. Draw a line from there to a point halfway between the ala of the nose, the nostril flare, and the edge of the upper lip. Stenson's duct runs along the middle third of that imaginary line.
Pretty precise. Clinically, how do you best feel the gland itself?
For palpation, you use the masseter muscle. You ask the patient to clench their jaw, tighten that muscle up. Then you use a bimanual technique. One finger inside the mouth, pushing outwards, and the other hand pressing on the cheek from the outside, posteromedially. This rolls the gland and anything firm inside it, like a stone or a tumor, right over that tensed masseter. Lets you feel its consistency, check for tenderness, swelling.
Got it. Okay, moving down to the submandibular gland, it basically defines a whole region of the neck, doesn't it?
It really does. It's the main structure in the submandibular triangle, which surgeons classify as level IB of the neck. That's a critical landmark for lymph node drainage cancer staging.
And where is it located exactly?
Its main superficial part sits between the body of the mandible and the mylohyoid muscle, that sheet-like muscle forming the floor of the mouth. It's usually quite easy to feel bimanually, too.
And we need to remember its J shape, right? Where it hooks around the back of the mylohyoid?
Absolutely essential point. The submandibular gland isn't just one lump. It has that larger superficial part you feel in the neck, but also a smaller, crucial deep part that extends up into the floor of the mouth. That hook around the posterior edge of the mylohyoid connects the two.
Okay. Finally, the sublingual gland. Smallest of the three majors. Flat, narrow, maybe only 2 centimeters long, but packed with important neighbors.
Very much so. This is the one sitting right under the oral mucosa, just superior to those floor of the mouth muscles, the geniohyoid and mylohyoid. Identifying it intraorally is straightforward. Ask the patient to lift their tongue towards the roof of their mouth.
And you see.
You'll see that raised midline ridge, the sublingual fold or plica fimbriata. That fold marks the line where all those little ducts of Rivenus open up.
And the key relationships here, that this sounds like the surgical minefield part.
It's tight quarters. Superiorly, there's just the thin oral mucosa. Inferiorly, you've got the submandibular gland itself and the mylohyoid muscle. And critically, running right through this neighborhood, the lingual nerve passes anteriorly, and then posteriorly, both the lingual nerve and the submandibular duct are in very close proximity.
Wow.
It's a tiny space, but a major crossroads for vital plumbing and wiring. Really demands respect.
Okay, let's shift now into the core surgical challenge. Parotidectomy. The goal of a superficial parotidectomy seems simple. Take out the lesion in the outer part, but doing it safely is all about the facial nerve, CN7. Before we even get to the nerve, though, we have to navigate this layer called the SMAS. What is that?
SMAS stands for Superficial Muscular Aponeurotic System. Think of it as like the face's natural cling film or internal scaffolding. It's this crucial fibrofatty layer that wraps around the muscles of facial expression and anchors them to the skin, the dermis.
So it connects muscle to skin.
Right. And it forms a continuous sheet. Downwards, it blends with the platysma muscle in the neck. Upwards, it connects with the superficial temporal fascia over the temple.
Why is recognizing this specific layer so vital for the surgeon?
Because the depth of the facial nerve branches changes relative to it. This is critical. In the lower face, the nerve branches run deep to both the SMAS and the platysma muscle underneath it.
Okay.
So the safest initial dissection plane, to avoid hitting those nerves early on, is kept above the SMAS. You stay superficial to it.
But it changes in the neck.
Exactly. When you're working lower down in the neck, specifically trying to protect the marginal mandibular branch, the one that controls the lower lip, the surgeon needs to perform a very meticulous subplatysmal dissection.
Meaning under the platysma muscle.
Yes. You lift the platysma muscle flap and dissect carefully just beneath it. Why? Because that marginal branch often runs within the fascia covering the platysma, or sometimes just deep to it. Lifting the platysma provides direct visualization and the best protection for that vulnerable nerve.
And the SMAS itself, being kind of inelastic, has another clinical relevance.
It does. The sources mention that because the SMAS doesn't stretch much, it contributes to the significant, often throbbing pain people feel with acute parotitis mumps, for example. The gland swells up, but it's trapped inside this tight covering with nowhere to go.
Ouch. Okay, let's get to the nerve itself. The facial nerve, CN77. It pops out of the skull at the stylomastoid foramen. How quickly does it branch out?
Almost immediately. It enters the parotid gland substance right away, and usually within about 2 centimeters of entering, the main trunk divides. This division point is called the pit, and Cernus means goosefoot because of the way it splits.
Into two main trunks first.
Typically, yes. Into the upper zygomaticotemporal trunk and the lower cervicofacial trunk.
And from those, we get the famous 5 terminal branches everyone learns: temporal, zygomatic, buccal, marginal mandibular, and cervical. Now, there's this concept that often confuses people: the surgical lobes versus the actual anatomy.
Wait, so if surgeons talk about removing the superficial lobe, does that mean there's actually a membrane or something separating it from a deep lobe?
That's a great question, and the distinction is really important. Anatomically speaking, there is no actual separation between a superficial and deep parotid lobe. The gland tissue is continuous.
Oh, okay.
The facial nerve simply acts as a surgical plane that runs through the gland substance.
Right. So superficial and deep are just surgical terms relative to the nerve. Superficial means lateral to the nerve branches. Deep means medial to them. It's all about the nerve's position.
But radiologists use a different landmark.
They often do. Radiologists tend to use the retromandibular vein as their dividing line on scans like CT or MRI. The vein is large, usually easy to see, and pretty consistent. It serves as a reliable plane for describing tumor location on imaging, even though the nerve is the actual surgical divider.
Okay, so to start the surgery safely, the surgeon needs to find the main nerve trunk before it branches. There are classic landmarks for this anterograde identification. What are they?
We rely heavily on bony and muscular cues to estimate where that trunk emerges. The first is the tympanomastoid suture. It's a bony ridge you can feel just behind and below the ear canal opening, the EAC.
And the nerve is near that.
Very near. Classically, the facial nerve trunk is located up to 6 millimeters below the suture line. It's a pretty reliable, hard landmark.
Then there's the tragal pointer, Sounds specific, but sources say it can be misleading.
The tragal pointer of Conley. It's that little pointed piece of cartilage extending down from the tragus. Historically, it was a key guide, but yeah, its position varies quite a bit between people.
So not totally reliable.
Classically, the nerve is said to be about 1 centimeter medial and inferior to its tip, but surgical experience shows it's not consistently reliable. You use it as a rough initial guide, maybe, but don't bet the farm on it.
So what's considered the most reliable muscular landmark then?
That would be the posterior belly of the digastric muscle. You identify where this muscle attaches to the mastoid process behind the ear. The nerve trunk, which is only about 2 to 3 millimeters in diameter here, is reliably found running just above the superior edge of this muscle belly. Following that superior edge back towards the skull base is the standard, safe way to find the trunk.
Is there a blood vessel nearby to be aware of?
Yes, the posterior auricular artery. This vessel actually crosses over the main facial nerve trunk right near the stylomastoid foramen. So seeing the artery is a good warning sign that the nerve is immediately adjacent, but you have to carefully ligate or control this artery to get good exposure and stop bleeding before you can properly dissect the nerve itself.
What if the main trunk is just impossible to find initially, maybe due to scarring or a tumor? Can you work backwards?
Absolutely. That's the retrograde technique. You find one of the larger distal branches out in the face, say the marginal mandibular buccal branch, and carefully trace it backwards towards the pesa serenus and the main trunk.
Is there a surface guide for the temporal branch, which seems quite exposed?
Yes, for the temporal branch, we use the Patangi line. It's an imaginary line running from about 1 centimeter below the tragus up towards a 1.5 centimeter superolateral to the eyebrow. That line approximates the course of the temporal branch as it crosses the zygomatic arch, where it's quite vulnerable.
Now, connecting anatomy to potential problems, you mentioned earlier that only 2 of the 5 branches are really susceptible to permanent palsy if injured. Why is that?
It's all about cross-connections, or anastomosis. The 3 mid-facial branches, zygomatic, buccal, and cervical, tend to have multiple interconnections between them, like a safety net. If one little twig is cut, function might recover or be compensated for by the others.
But not the temporal and marginal mandibular.
Right. The temporal branch, going to the forehead, and the marginal mandibular branch, going to the lower lip, generally lack these significant backup connections. So if you damage those 2, the resulting paralysis is much more likely to be permanent.
And what's the functional loss specifically, if the temporal branch goes?
You lose the ability to wrinkle your forehead on that side because the frontalis muscle is paralyzed. This leads to a droopy eyebrow, ptosis, and sometimes difficulty closing the eye completely.
And if the marginal mandibular branch is injured?
You lose function in the depressor anglioris muscle mainly. This causes the lower lip on that side to droop or appear flattened. The patient can't pull the corner of their mouth down properly, leading to an asymmetric smile and sometimes issues with drooling. It's a significant cosmetic and functional problem.
Okay, we also need to summarize the vascular anatomy within the gland. There's this concept of a vascular sandwich. What's the depth order?
This is a critical mantra for parotid surgery. The gland essentially holds these key structures in 3 layers, from deep to superficial. Deepest is the external carotid artery giving off its terminal branches, like the superficial, temporal, and maxillary arteries.
Okay, artery deep.
Middle layer. The facial nerve branches themselves passing through the gland.
Nerve in the middle.
Most superficial layer. The retromandibular vein, which is formed inside the gland by the joining of the superficial temporal and maxillary veins, so the order is external carotid artery, right arrow, facial nerve, right arrow, retromandibular vein, deep to superficial. Knowing this helps you anticipate what structure lies just beneath the one you're currently looking at.
Makes sense. Finally, total parotidectomy. Less common, suggests more complexity.
Yeah, total removal is usually reserved for more advanced cancers, or sometimes benign tumors that arise in the deep lobe, medial to the nerve. Because there's no real anatomical barrier, you have to remove that deep part, which means carefully lifting or dissecting the facial nerve branches out of the way to get access.
And lymph nodes can be deep too.
Yes, the sources note there are typically 1 to 2 lymph nodes located deep medial to the facial nerve plane. If those nodes are involved with metastatic cancer, a total parotidectomy is often necessary. In really radical cases for aggressive cancers, the surgery might even involve removing parts of the nearby temporal bone, TMJ, mastoid, ear canal.
Wow. And the classic long-term complication after extensive parotid surgery. Fraze syndrome. Sounds like
Good.
faulty wiring.
That's exactly what it is. It's called aberrant reinnervation, a type of synkinesis. What happens is, after surgery, the parasympathetic nerve fibers that used to go to the parotid gland to stimulate saliva production start regenerating.
Right.
But instead of finding salivary tissue, which might be gone, they mistakenly grow into and connect with the denervated sweat glands and tiny blood vessels in the overlying skin flap. These nerves normally travel in the auriculotemporal nerve.
So the signals get crossed.
Completely. The trigger for salivation eating, thinking about food, now activates these misconnected nerves. But instead of producing saliva, they cause the sweat glands in the skin of the cheek and temple on that side to activate, leading to profuse sweating and sometimes flushing whenever the patient eats. Gustatory sweating, it's called. Very characteristic.
All right, let's shift focus now down to the submandibular gland and its removal. Indications here are often things like chronic infections, recurrent stones, silolithiasis, or sometimes the gland is taken out as part of a larger level 1 neck dissection for cancer. This area seems less about huge tumors and more about navigating tight spaces around 3 specific major nerves. Let's start with the nerve most at risk during the initial skin incision. The marginal mandibular nerve, MMN.
Yeah, the MMN is rightly called the cosmetic hazard. It's purely motor, supplying the depressor anguli oris muscle, which pulls the corner of the mouth down, and also parts of the platysma. Damage here is immediately obvious and functionally annoying.
Functionally, what does the patient notice if it's injured?
Well, apart from the visible cosmetic issue, that flattening or even inversion of the lower lip on one side, they often have trouble keeping fluids in their mouth, leading to some drooling. And they can't properly pull the corner of their mouth down and outwards, like when baring their teeth or making certain expressions.
So, placing the incision safely is paramount. What are the key measurements or guidelines?
Studies generally show the nerve runs less than 1.75 centimeters below the lower border of the mandible on average, but averages can be deceiving. So the standard surgical rule is to place the skin incision at least 2 centimeters below the mandible.
Like 2 fingers breadth.
Exactly, that's the common guide. Gives you a reasonable safety margin below where the nerve is most likely to be.
Is there a relationship with the facial artery and vein that helps protect it too?
Yes, there is. The MMN's exact position varies, but relative to the facial artery and vein, it's more predictable. If you feel the pulse of the facial artery where it crosses the jawbone, anterior edge of the masseter muscle,
Right.
the nerve usually runs superior to the mandible border anterior to that artery, so it tucks up a bit there. More practically, though, surgeons often use the facial vein as a kind of shield. You find the vein, tie it off, ligate it, and then carefully lift the upper part of the tied vein superiorly towards the mandible.
And that lifts the nerve with it.
In most cases, yes. The nerve often runs just superficial or within the fascia around the vein. So reflecting the vein upwards retracts and physically protects the MMN while you work deeper on the gland itself. It's a very common and useful technique.
Okay, moving deeper. Nerve number 2. The hypoglossal nerve, CN12. This is the main motor supply to the tongue, critical for swallowing and speech.
Absolutely critical. CN12 supplies all the intrinsic and extrinsic muscles of the tongue, except for one, the parotidectomy muscle that gets its nerve supply from the vagus nerve, CNX, via the pharyngeal plexus.
Where does the hypoglossal run after leaving the skull?
It exits the hypoglossal canal and takes this important path down between the internal carotid artery, ICA, and the internal jugular vein, IJV.
And it picks up some hitchhikers, fibers from the neck nerves.
It does. It gets accompanied by nerve fibers from the C1 and C2 spinal nerves. The C1 fibers travel with the hypoglossal for a bit before branching off to form the superior root of the ansa cervicalis, that loop of nerves supplying the strap muscles in the neck.
So the hypoglossal itself isn't the only thing running in that bundle.
Exactly. Makes the whole complex important. Now, finding the nerve surgically in level I in the submandibular triangle.
Yeah, where do you look?
As it comes forward, it runs relatively horizontally across level I, key relationships. It passes superior to the surfaces of both the ICA and the external carotid artery, ECA, and it runs medial to the posterior belly of the digastric muscle. Surgically, the classic view is when you retract the submandibular gland downwards and outwards. You'll then see the hypoglossal nerve running horizontally just below the posterior belly of the digastric.
Is there a specific warning associated with dissecting near it? Something about bleeding?
Yes, very much so. This is a high-risk spot for annoying, obscuring bleeding. The hypoglossal nerve is often accompanied by small veins called the Renin veins, or veni comitantes.
Companion veins.
Right. If you nick these, they can bleed quite a bit, making it hard to see the nerve clearly and increasing the risk of injuring it. That's why using electrocautery or diathermy near the nerve sheath has to be done with extreme caution. Heat can travel and damage the nerve fibers even without direct contact.
And if the hypoglossal nerve is damaged, what's that classic, unforgettable sign?
When the patient sticks their tongue out, it deviates towards the side of the injury.
Towards the weak side. Seems counterintuitive.
It does, but it's because the main muscle that pushes the tongue forward, the genioglossus, is paralyzed on the injured side. So the healthy genioglossus on the other side acts unopposed, pushing the tongue over towards the weak side.
Got it. Any other symptoms?
Yes, long-term injury leads to visible wasting or atrophy of the tongue muscles on that side. Functionally, patients have trouble with fine tongue movements needed for speech, particularly sounds like la and t. They might describe their speech as slurred or their tongue feeling heavy.
Okay, third and final major nerve in this area. The lingual nerve, V3. This one's mainly sensory, right? And it forms that famous X with Wharton's duct.
That's the one. The lingual nerve is a big, flat nerve, a branch of the mandibular division of the trigeminal nerve, CNV3. Its main job is providing general sensation, touch, pain, temperature to the front two-thirds of the tongue on the same side.
But it carries other fibers, too.
Crucially, yes. It carries the chorda tympani nerve, which is actually a branch of the facial nerve, CN3, that joins the lingual nerve higher up. The chorda tympani carries taste sensation from the anterior two-thirds of the tongue, and also the parasympathetic nerve fibers that will eventually supply the submandibular and sublingual glands after synapsing in the submandibular ganglion.
Okay, let's break down that critical X relationship with Wharton's duct. How does the nerve cross the duct?
Right. So as Wharton's duct emerges from the deep part of the submandibular gland and runs forward in the floor of the mouth, the lingual nerve is initially found running superior to the duct.
Nerve on top of the duct first.
Correct. But then, as the nerve continues forward, heading towards the tongue, it changes course and dips underneath Wharton's duct, crossing it from the medial side to the lateral side.
So it goes from above to below, crossing over.
Exactly. That crossover creates the anatomical X configuration, and that junction is the spot where both structures are most vulnerable during surgery on the gland or the duct itself.
Lingual nerve injury is maybe more common in wisdom tooth surgery, but if it happens during submandibular gland removal, what are the symptoms?
Since it's primarily sensory to the tongue, the main symptom is sensory loss. Numbness, tingling, or altered sensation, anesthesia or paresthesia in the ipsilateral anterior two-thirds of the tongue.
And maybe taste changes.
Possibly, yes, because of the chorda tympani fibers it carries. The patient might report altered taste on that side as well.
Okay, just to wrap up the submandibular region, let's quickly touch on the muscles that act as key landmarks. The digastric and the mylohyoid.
The digastric muscle, with its two bellies, forms the lower borders, antero-inferior and postero-inferior, of the submandibular triangle, level 1. The posterior belly is particularly useful because key structures like the facial artery and the hypoglossal nerve lie directly deep to it. So the muscle acts as a guide to find those deeper structures.
And the mylohyoid muscle. It separates the gland portions.
Exactly. The mylohyoid forms the muscular floor of the mouth and physically separates the submandibular gland into its superficial part in the neck and its deep part in the floor of the mouth. The crucial surgical insight here is that both the lingual nerve and the hypoglossal nerve run deep to the mylohyoid.
So staying above the muscle keeps you safe initially.
When you're dissecting the superficial part of the gland in the neck, staying superior to the mylohyoid muscle generally keeps you away from those major nerves, which are located underneath it in the floor of the mouth proper. It acts like a protective muscular roof during the initial part of the dissection. #TAG66. Deep dive into sublingual gland surgery and ranula management. Okay, finally, let's focus on the smallest of the major glands, but maybe the most superficially located one, the sublingual gland, and its main associated problem, the ranula.
Ranula, funny name, comes from frog.
It does, from the Latin rana, meaning frog. Apparently, the bluish, fluid-filled swelling under the tongue can resemble the translucent underside of a frog's belly.
Anatomically, what exactly is a ranula? You mentioned it's extraductal and extraglandular.
Right, that's the key definition. A ranula is a collection of leaked mucin in the floor of the mouth that originates from the sublingual gland. But it's not a true cyst with an epithelial lining. It forms because one of the gland's tiny ducts likely ruptures or leaks, and the mucus spills out into the surrounding soft tissues, forming a pseudocyst.
So it's leaked mucus walled off by inflammatory tissue, not a true developmental cyst.
Precisely. And knowing it's basically leaked mucus guides the surgical approach.
So for a straightforward intraoral excision of a simple ranula, What structures are right there, most at risk during that delicate dissection under the mucosa?
The technique involves making an incision in the mucosa overlying the swelling, trying carefully not to pock the ranula itself if possible, and then dissecting it out submucosally. The structures lying just deep to the ranula sac are the main hazards: the submandibular duct, Wharton's duct, and the lingual nerve.
Which one is considered more at risk?
Generally, the submandibular duct is thought to be most at risk. It runs right across this area from lateral to medial to open near the frenulum, exactly where ranulas tend to form, so it's very close by.
And if the problem is more severe or recurrent, requiring removal of the entire sublingual gland itself, how do you find the gland and what's the main hazard then?
The gland itself is located just beneath the floor of mouth mucosa, lying anterior to the submandibular duct. It can actually be quite spread out, sometimes extending right up to the midline under the tongue, so it can be deceptively large.
And the primary hazard during its removal?
It remains, without a doubt, the submandibular duct, Wharton's duct. It's the most superficial, significant structure you encounter when working in the floor of the mouth here, and it absolutely must be identified and protected while the sublingual gland tissue is dissected away from it.
So this brings us back to that intricate X area one last time, where the lingual nerve and duct cross.
Absolutely critical. The whole dissection strategy revolves around finding Wharton's duct, carefully freeing it up, and then removing the sublingual gland tissue from around it. You have to pay extremely close attention, especially in the posterior part of the gland, where the lingual nerve dives underneath the duct, that X area.
You need to keep track of the duct's path.
Constantly. Remember its orientation, running obliquely forward and medially, quite superficially, tracing roughly from the frenulum back towards the wisdom tooth area, retromolar trigone, on that side. Dissection here demands really good knowledge of the microanatomy and extreme care with every instrument movement.
Okay, we have covered a huge amount of detail across 3 major glands and navigated the paths of, 4 major nerves: facial, marginal mandibular branch, hypoglossal, lingual. Let's try to synthesize this down to the absolute must-know mastery-level takeaways for anyone operating or thinking about this region.
All right, 3 crucial points. First, let's reiterate the risk of permanent facial nerve palsy. Remember that anatomical vulnerability. It's primarily the temporal branch and the marginal mandibular branch that lack those backup anastomoses.
The safety net.
Exactly. So injury to those 2 specific branches is significantly more likely to result in a permanent deficit, the forehead paralysis or the lower lip droop, compared to injuring the midfacial branches. Know which ones are high risk.
Okay, takeaway number 2. The single most defining sign of hypoglossal nerve injury.
That is the unmistakable pathognomonic symptom. The deviation of the protruded tongue towards the side of the lesion. Tongue points right. Right nerve is injured. It's the essential diagnostic clue.
And third, how to differentiate lingual nerve injury from hypoglossal injury based on symptoms.
Lingual nerve damage is purely sensory loss. Numbness, tingling, altered sensation, anesthesia, or paresthesia of the anterior 2/3 of the tongue on that side. If the patient complains of tongue numbness, think lingual nerve. If they complain of tongue weakness or deviation, think hypoglossal.
Clear distinction. And finally, let's just quickly list those 3 key surgical landmarks again for safely finding the facial nerve trunk near the stylomastoid foramen.
The reliable bony landmark. Tympanomastoid suture, the most reliable muscular landmark. Posterior belly of the digastric. And the classic, but less reliable, guiding landmark, the tragal pointer. Know those 3, and you have a safe starting point for the dissection. You know, what's truly remarkable when you step back is just the sheer density and complexity packed into such a small anatomical space. You have essential motor nerves, sensory nerves, parasympathetic pathways, major arteries and veins, all converging here. It really underscores why navigating this area safely requires such specialized, detailed knowledge, not just where things are, but their precise 3D relationships and functional importance.
It really does. And that complexity brings us to our final thought for you, our listeners, to maybe ponder further. We've spent a lot of time discussing anatomical averages. The marginal mandibular nerve is usually less than 1.75 centimeters from the mandible. The facial nerve typically divides within 2 centimeters.
Yeah.
But we also know that individual human anatomy, especially nerve branching patterns and precise locations, can be highly variable.
Very true.
So the question to consider is, how does a surgeon truly bridge that gap? How do they reconcile relying on these important anatomical averages from textbooks and studies with the absolute real-time necessity of direct visualization, careful dissection, and sometimes intraoperative nerve monitoring to ensure safety for the unique patient actually on the operating table? It highlights that crucial difference between static book knowledge and the dynamic individual reality of surgical execution.
That's a great point. It's where the art meets the science, isn't it? Definitely something to think about as you continue on your own path to mastery in this field.
Indeed, fantastic discussion. We'll see you next time on The Deep Dive.